Hello, and welcome to the Principles of Intracranial Pressure 6-Minute Synapse series. In this session, Intracranial Pressure Explained, we will cover the basic concepts of intracranial pressure, or ICP. What is ICP? Causes of increased ICP, the Munroe-Kelly hypothesis, compliance, and the volume pressure curve. My name is Jessica Ray, and I am a neuroscience nurse and clinical specialist at Natus. When we talk about pressure, we're looking at something pushing or applying force against something else. Here, ICP is the pressure created by the brain, blood, and cerebral spinal fluid, or CSF, pushing against the confines of the cranium. ICP gives us a global view of changes in the volume of the cranial contents and allows us to monitor perfusion of blood into the brain. The cranium, because it's bone, has a fixed volume available to house the brain, blood, and CSF. It is a closed, rigid container. Like a box, it can only hold a certain amount before reaching maximum capacity. An increase in the volume of any one of the cranial contents takes up more space. The more crowded the cranium becomes, the more it pushes against the walls of the skull and increases ICP. If ICP is higher than the mean arterial pressure, or MAP, then the brain is not being adequately perfused. Inadequate perfusion can lead to secondary injuries such as ischemia and infarction. This is why it's so important to ensure that there is adequate space in the closed box. Because there is only so much room, anything that would expand the normal volume of the blood, brain, and/or CSF will increase ICP. Here we have CT scans that show examples of increases in one of the cranial components. Starting from the left, we see an increase in blood volume due to a subarachnoid hemorrhage. The middle scan shows an increase in brain mass due to an infarct. The scan on the right shows an increase in CSF volume due to hydrocephalus. The increase in volume in any one of these components increases the pressure exerted in the cranium. So what exactly happens when there's an increase in the volume of one of the intracranial components, like blood, for example, due to an interparenchymal bleed, as shown in the CT scan in the top right? How is equilibrium, and therefore ICP, maintained? By keeping the total sum volume of the contents of the cranium relatively constant, i.e. the Munroe-Kelly hypothesis. On the diagram on the left, we see brain, blood, and CSF in their normal allotted volume ratios. The brain comprises about 80% of the cranial volume, blood and CSF about 10% each. To maintain equilibrium, the volume of one cranial component will lead to a complementary change in volume of the other. As one part increases, another part will decrease. This is demonstrated in the diagram on the right. Note how the large square houses the three components, remains the same overall size despite the changes in the amount of blood and CSF. This push-pull of dimensions maintains the total sum volume of the cranial contents. Compliance is the system's ability to accommodate for that increase in volume, whether it be blood, brain, or CSF, while keeping pressure within normal limits. These diagrams show compliance in action. Notice how the size of components shift to accommodate a mass lesion to maintain total volume and therefore normal pressure. One main compensatory mechanism is to increase drainage of CSF and/or venous blood to reduce their cranial volume, as seen in figures 2 through 4. This is why it's so important to have the head align with the neck and elevate the head of bed to 30 degrees to aid in this drainage. When the system has lost compliance, as seen in figure 4, it can no longer do the push-pull and volume adjustments. It has lost its ability to accommodate any expansion in volume, and ICP then increases past normal limits. Compliance can be limited by the rate of expansion of the mass lesion, cerebral hemodynamics, and ability to drain CSF. Loss of compliance may result in herniation and ultimately brain death. What is the range of normal pressure? And at what point would we begin to consider treatment? Normal pressure range is 0 to 15 millimeters of mercury. Compliance is intact. In fact, Compliance remains intact, for the most part, for pressures up to 22. The Brain Trauma Foundation's 2016 guidelines recommends treating ICP above 22 millimeters of mercury, as ICPs above this number have been correlated with poorer outcomes. Always defer to your patient's specified orders for ICP treatment parameters and interventions. We use ICP to calculate and monitor cerebral perfusion pressure, or CPP, to ensure that the brain is getting adequate blood flow. CPP is found by subtracting the ICP from MAP. As you can see by the equation, in order to have a positive perfusion pressure, MAP must always be greater than ICP. If ICP is greater than MAP, blood cannot flow into the brain and perfusion is compromised. Now that we reviewed the why and how of ICP, let's take a look at how ICP and volume of intracranial components are related. The volume pressure curve illustrates the positive correlation between ICP and intracranial volume. As we've seen, when there is something that takes up more space inside the cranium, a bleed, infarct, or buildup of CSF, things become more crowded and exert more pressure. If compliance is intact, the system can adjust and there is little or no increase in pressure. However, if the lesion increases in size faster than the system can accommodate, such as with the rapid bleed that's seen with an epidural hematoma, it compromises the system's ability to regulate intracranial volume, and compliance may be quickly lost. Once compliance is lost, the system can no longer adjust. Any small increases in volume will then lead to exponential increases in pressure. In summary, there is only so much room. Once the volume of the cranial contents have reached maximum capacity and the system can no longer adjust, compliance is lost. Both ICP and perfusion are compromised, leading to poorer outcomes and possibly brain death. These are the references for this presentation. Thank you for joining this presentation. If you have questions or comments, please feel free to email me at jessica.ray@natus.com.